Medical management of post-cardiac surgery. We will, three, four talks, try to get some consensus that what should be the medical management. And maybe this may be the foundation stone for getting some guidelines. You see, my weakness is always that evolve some guidelines, minimum possible guidelines, which should be followed by everybody. This may help you sometimes in court of law also. And that was the genesis of when we drafted, AIOS guidelines for infection control also. So we have to learn each other, and believe me, this is a dynamic thing. Whatever is sacrosanct today may not be tomorrow also. So with this small intro, we'll begin with none else than Master Kamal Bandhu KAPUR, who will tell us about the role of Moxi-Dexa combination. Because all surgeries will have some itis component, inflammation also, and some pain. So my friend Kamal KAPUR will tell us about this.
A very, very good morning to everybody. Thank you, Dr. Lalit. I would agree, there is a spectrum of...
I will request Mujta to please join us here.
Could you please put on my presentation? There is a spectrum of post-operative regime which all of us would be following. It can vary from the place you're working at, the competition around, whether you're a corporate or non-corporate. Yes, I agree. There are a lot of factors which do play in. But there are some sacrosanct rules. Sorry. There would be some baseline protocols, I think, which we can have a common agreement on. And one of them is a fixed dose combination of a steroid and an antibiotic. So we know, nearly 2% of patients beyond the age of 50 are suffering from cataract. Cataract is one of the most performed ophthalmic surgeries. And the best part is the patient has to go through it twice at least. And God forbid there's no complication, then maybe more. So maximum cause of blindness, clear corneal incisions, definitely all the literature has shown to us that the increased incidence of infections are there. And what would be the management strategies? There are two strategies. One is you have to avoid your post-operative infections and, of course, inflammation. And eye, as ocular surface, as we all know, is a very sensitive organ. It is more prone to surgery-induced inflammation. And another dictum which follows is longer the surgery, more the inflammation. More the manipulation of tissue, more the inflammation. So these things are quite common. So what I would say is, to prevent the infections, you use antibiotics, and to prevent the inflammation post-operative, you use the NSAIDs and a combination of steroids. So what are the peak signs which you may see? You see pigment dispersion, you see iritis, you see uveitis, intraocular pressure rise, pupillary block, posterior capsular opacification, and posterior synechia. And the infections are one of the most feared complications of cataract surgery. And I'm sure all of us as cataract surgeons, our heart skips a beat when you get a call in the middle of the night from a patient, Dr. Saab, pain ho rahi hai and I cannot see. It could be intraocular pressure rise, it could be a Desmond folds, it could be a corneal opacity, but your heart skips a beat because you may be looking at a post-operative infection, and that can be very, very catastrophic. And some of them are no fault of the surgeon. You could have a flora from the patient's eye, skin around the eye, hygiene, whatever. But the blame entirely falls on the surgeon. So how do we stack up? What are the common causes of the bacteria which you see around in the market in your practice, especially in India? What are the kind of bacteria you see? You see, Coagulase negative staph and streps are very, very common. But sometimes you may get a gamut of Pseudomonas. And that is scary because Pseudomonas, at least in my experience, is one of the most devastating infections which a doctor can have in his post-operative patients. So if you see actually that the most post-operative endophthalmitis is seen in cataract, and logic says yes, because it is the most performed surgery. But there are other reasons why you get more infections in cataract. We'll see that. So the incidence actually varies from 0.03 to 0.2% across the spectrum, across many very developed countries and our country. So why cataract surgery is the most common factor causing endophthalmitis? Of course, because it's the most performed surgery. And second, it's performed in usually the elderly people. Now, elderly people are more prone to surface disorders. Now, let's not take surface disorder lightly. Surface disorder not necessarily just gives you a bad visual outcome and post-operative headache because the patient keeps coming to you saying itching, watering, but surface disorders also cause increased incidence of infections because the protective enzymes in the tear film are actually bad for the bacteria to grow. So you have these patients who are more prone to blepharitis, they are immunocompromised, they are patients with arthritis, usually on steroids sometimes. Hard mature cataracts, again, denotes most of these patients will come to you with hard cataract. You have longer surgical times. You have wound burns, you have fish mouthing of the wound, you have damage to the descemetes. So hard cataracts, of course, are prone, uveitis, MGD. A combination of povidone, at least in my practice we do a practice of cleaning the area with povidone prior to surgery, and after that is done, we take away any tissue paper or handkerchief with the patient. Because a lot of times patients feel a little wet on the eye, he uses a tissue or a hanky to wipe the povidone again. So the person who paints before the operation theater tells the patient, now don't touch your eye. So the povidone painting is done at least 4 to 5 minutes before the patient comes into the theater. After the speculum is put, at least 1 minute of wet soak time of Apadine or no commercial interest here in the phonics, and then a combination of intracameral or postoperative steroids. Now, what is the actual regime ideal? Ideal regime would be to use the antibiotic steroid combination not for more than 7 to 10 days, because after that, if you're just pushing more antibiotics, you're probably just helping resistance come up. Because by now the wound is closed, everything is settled. What you need to take care of is a delayed inflammation. So it's a good idea to shift the patient from antibiotic steroid combination to a low-dose steroid or an NSAID combination. So preoperative prophylaxis, 3 to 4 days prior to the surgery, we put the patient on an NSAID and an antibiotic. During the surgery, choice of the surgeon in my organization, you want to use an intracameral, like I personally don't use an intracameral, but a lot of people in my team do use it, so there is no hard and fast rule. I'm sure there could be a consensus here, but it depends from surgeon to surgeon. Topical broad-spectrum antibiotics, the moment surgery is finished, we put a drop of Moxifloxacin in the eye in a combination with steroid, and topical antibiotics steroid combination 7 to 10 days. So there was a consensus, there was a survey conducted, nearly 78% of most of the surgeons prefer using a Moxi-Dexa combination. This is, again, not a rule, but this is a statistical evaluation which was done. And studies have proven that the dexamethasone has got the most potent anti-inflammatory effect, better than prednisolone also. Though prednisolone may have a better penetration into the vitreous, but dexamethasone actually is more potent anti-inflammatory in these patients. And a combination of moxifloxacin and dexamethasone is a stable combination. You do not usually need a lot of preservatives here. And studies have proven that dexamethasone actually gives you a better post-operative anti-inflammatory control, and has got a longer duration of action. And of course, a combination with NSAID. Now, as Dr. Lalit did mention, use of lubricants. I personally feel when you do an ocular surgery, it's an insult to the tear film and the corneal epithelium. You need to give the poor epithelium some time to regrow. So my combination, ideal combination, would be to put these patients on a sodium hyaluronate combination, because let's face it, sometimes the patients need an anti-glaucoma, and we all know most of the anti-glaucoma agents are bad for your tear film. Secondly, if you're using an NSAID, Nepafenac, Bromfenac, they are epitheliotoxic. And sometimes you need to use an antibiotic, aminoglycoside. They are super toxic to your epithelium. So you need to give a cover of lubricant. So an efficacy combination of steroid and a antibiotic is a good idea because its compliance is good. You can actually give the patient, use it more of it rather than using combinations, and it's got a better penetration than gadifloxacin. 100 patient studies have proven that with the combination of dexamethasone are pain-free, and most of the results have shown that this is an ideal combination, and as I recommend, 7 to 10 days is an ideal time for using an antibiotic steroid combination. So what I would recommend, what we practice in my practice is a use of an NSAID and an antibiotic 3 days prior. If I have a patient of dry eye, I put these patients on cyclosporin at least 1 week before, and a sodium hyaluronate, because these are the patients you could do a perfect surgery. The patient, even after an EDOF or a multifocal, could be 6'6" and 6", but he's not going to be happy with a fluctuating vision because of a bad dry eye pre-existing. So you could do the best surgery possible. If you're not taking care of the surface disorder, infection is not there, inflammation is not there, but guess what? You have an unhappy patient. So I personally recommend correcting the surface disorder prior to the surgical procedure. Thank you.
Thank you, Kamal, for elaborating these points. A lot of these points, whatever he has spoken, may be, not evidence-based. Some of them may be evidence-based. So you see, we all have evidence-based guidelines and experience-based guidelines. So I agree there are two aims: to avoid inflammation, avoid infection. Infection, in any case, I think there are a lot of guidelines available. But the use of pre-operative antibiotic is not agreed upon, not a evidence-based. There is hardly any evidence which supports, or level 1 evidence does not exist to the, for usage as a routine.
Absolutely.
Only in some one-eyed or maybe eyes at risk, they may be, but otherwise, by and large, no. You rightly said, povidone is one thing which is level 1 evidence.
Absolutely.
And one thing which I would like to highlight, which he has highlighted, the contact time. I have seen a lot of, even at our setup, you put iodine and it's just nurse scrub nurse washes immediately. That is befooling yourself, because it has to have a contact time of minimum of 1 minute in the sac. On the skin, they say 5 minutes, but in this sac, it has to be for at least 1 minute. Mohita, you want to say something?
About cyclosporin preoperatively, you said that if there is dry eye, you would, almost all our patients have dry eye in that age group.
Okay, I would
and that is one. And then cyclosporin, would it act so fast that if we started 3 days pre-op, would it have its action actually?
Absolutely, a very good point. Let's all agree, cyclosporin does have an immunomodulator and anti-inflammatory effect also on the surface. And in combination with sodium hyaluronate, because these patients, probably some of them are already on, as you said. So what I'm referring to are patients who have a bad documented dry eye. And most of these patients are on your follow-up priorly also. So some of them are on a combination of cyclosporin and even liftigras. I have a lot of patients on liftigras.
The thing is, here we should have minimal possible guidelines rather than the maximum possible guidelines. If you give so many pre-operative,
so I guess let's stick to having a sodium hyaluronate to start
with. If you ask any patient to put any pre-operation to put so many drops, compliance will go down.
Absolutely.
Before you came, I spoke that.
And as is being, since we are talking about guidelines and there are newer treatments available now, some people are recommending, if there is a dry eye and MGD, to one sitting of
ELP.
therapy before the surgery, and then continue with 2 more or 3 more sittings later. Would you recommend that?
Okay, I think this is a very good point. If you do an ELP, I would recommend at least 15 days of time duration and at least 2 sessions of lid massage to express the bad sebum out, because sometimes just after ELP, you may have sudden gush of bad sebum coming out, which is loaded with inflammatory markers.
Yes,
I have attended Dr. Rohit Chetty's amazing lectures, and these pent-up sebum gland secretions have inflammatory component in them.
So that's a very good point, because nowadays some people are doing, this practice has been started, that do a therapy, pulse therapy, and then 3 days later do a cataract surgery. I think this is not to be recommended. If a therapy has to be done, it should be how many days after surgery? At least 2 weeks after the surgery and cataract surgery, and the patient can be primed about this, that you need this also. You already have a pre-existing dry eye, so this treatment may be needed for you 2 to 3 weeks later.
This is a very nice point. This is a very nice point, because cataract surgery is not a emergency kind of surgery. You could easily wait for this time. So meanwhile, we'll request Bandhu to get ready, because cover the questions we can take. We need to finish in time. Thanks, Kamal.
Prior to surgery, he said at least 2 weeks, because you don't want it to do it through 2 to 3 days before and have all the sebum load out.
These are not as a routine.
These are not routine cases. These are bad dry eye patients.
MGD or mebomyelitis, or if there is an active this thing.
One small point is, if your patient is suffering from an mebomyelitis, touch them with a 6-foot pole, at least till you've taken care of the mebomyelitis, because sometimes this can be very, very frustrating. So I give a combination of oral doxycycline with azithromycin drops. These are confirmed MGD cases where you need to operate.
I will